Hello and welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the GPnotebook study group presenters. This episode, we'll be discussing a condition that many healthcare professionals encounter but may not always recognise immediately: illness anxiety disorder, or IAD. Now, formerly better known as hypochondriasis, this diagnosis was redefined in the DSM-5 to better reflect the nature of the condition and to move away from terminology that had acquired negative connotations over time. Now, for GPs, illness anxiety disorder can present unique challenges. Patients often arrive to us convinced that a serious disease has been overlooked despite repeated evaluations and reassuring test results. And these consultations can be frustrating for both us and the patient, particularly when our traditional medical investigations fail to alleviate distress. So, illness anxiety disorder is characterized by a persistent and excessive fear of having or developing a serious medical illness. And what distinguishes it from many other health-related concerns is that the anxiety remains present despite appropriate medical evaluation and reassurance. These individuals become highly vigilant to bodily sensations that most people would regard as normal. So everyday experiences such as, for example, gut activity, transient discomfort, sweating, muscle tension, or normal fluctuations in energy levels may all be interpreted as absolute evidence of a severe underlying disease being present. Now, importantly, these patients typically have few or no significant physical signs, and so their distress arises primarily from their interpretation of bodily sensations rather than from the sensations themselves. Now, from a clinical perspective, it's useful to think of illness anxiety disorder as a disorder of health-related cognition. And what I mean by this is that the problem isn't simply worry, but rather the persistent misinterpretation of normal or minor bodily experiences as signs of catastrophic illness. And one of the reasons this disorder can be so difficult for us to manage is that reassurance typically provides only temporary relief. The patient may feel better immediately after receiving normal test results, but their anxiety soon returns, leading to renewed concerns, further consultations, and more requests for additional investigations. Now, the precise cause of IAD remains unclear, but several contributing factors have been identified. Many patients appear to have heightened sensitivity to bodily sensations, so they notice subtle physiological changes that others would ignore, and then interpret these as evidence of disease. Family influences may also play an important role here, so people raised in environments where health concerns were frequently discussed or where illness was viewed with significant anxiety may then learn to monitor their own bodies excessively. Children who experience serious illness themselves or who witnessed severe illness in close family members may also become particularly alert to signs of disease later in life. There's also a strong association with underlying anxiety disorders, since patients who are generally prone to anxiety may then channel that anxiety into concerns about their physical health. And in recent years, another factor has become increasingly relevant: unrestricted access to online medical information. And this phenomenon, often referred to as cyberchondria, can reinforce health fears, especially when individuals repeatedly search symptoms and encounter worst-case scenarios. And I know we've all had patients coming into our consulting rooms clutching several pages of health information that they found on Dr. Google and which they're convinced applies to them. Now, although illness anxiety disorder is now recognized as a distinct diagnosis, our understanding of its epidemiology is still evolving. And since the diagnosis was formally introduced relatively recently, prevalence estimates vary. However, it does appear to affect a small but clinically significant proportion of the population, occurring across all age groups, and which may emerge during adolescence, although some clinical observations do suggest that symptoms can become more pronounced with advancing age. Some studies have also found higher rates among individuals facing social or occupational disadvantages, although IAD can affect people from any background. Now, in primary care, the most important aspect of this condition is recognizing how it presents in our everyday clinical practice. Patients with IAD frequently seek care initially from GPs rather than from mental health professionals, as most of them don't perceive their difficulty as psychological at all. They genuinely believe they are suffering from an undiagnosed medical condition. So a typical scenario here would involve a patient who's undergone multiple examinations, laboratory investigations, and perhaps even specialist consultations. Yet despite consistently reassuring findings, the patient remains convinced that something serious has been missed. Some patients may express concerns that previous doctors failed to investigate them thoroughly enough. Others may believe that a rare condition has escaped detection, and it isn't uncommon for patients to seek multiple opinions in the hope of finding confirmation of their fears. Now, another common feature in my experience is repetitive self-monitoring. Patients may frequently inspect their skin, examine bodily changes, monitor vital signs, or search for subtle physical abnormalities. Thoughts about serious illness, disability, and even death can become persistent and intrusive, and the impact on daily functioning can be substantial. Relationships may become strained, work performance may decline, leisure activities may be avoided because of fears about health, and in severe cases, a patient's life becomes organized around their illness-related concerns. Now, interestingly, not every patient presents in the same way. Some become intensive users of our healthcare services, attending appointments frequently, requesting repeated testing, and consulting numerous specialists, whereas others take the opposite approach, avoiding healthcare settings altogether, simply because they fear receiving devastating news. And although these behaviors differ, both groups are driven by the same underlying anxiety. Now, when evaluating a patient, appropriate medical assessment is essential, and we should still remember the old medical truism I was taught decades ago. Even patients with hypochondriasis have to die of something. Now, the goal here is not to dismiss symptoms, but to ensure that any genuine medical conditions are identified and treated when present. But at the same time, it's important to recognize that a diagnosis of illness anxiety disorder doesn't require perfect physical health. Patients may have legitimate medical conditions and still meet the criteria for IAD if their fears and preoccupations are disproportionate to the severity of the actual disease. The diagnostic criteria themselves emphasize excessive concern about serious illness, minimal or absent somatic symptoms, persistent health-related anxiety, repetitive health-checking behaviors or reassurance seeking, and symptom duration of at least 6 months. And the condition must also not be better explained by another psychiatric disorder. The differential diagnosis here is particularly important because several psychiatric conditions can appear similar at first glance. And one of the closest comparisons here is somatic symptom disorder. And in this condition, patients experience distressing physical symptoms that become the focus of concern. Whereas in IAD, the primary issue is the fear of illness itself rather than the symptoms. Obsessive-compulsive disorder can also overlap, as patients with OCD may engage in repetitive checking behaviours and experience intrusive thoughts. However, OCD concerns usually extend beyond health and involve multiple domains of fear and compulsion. Generalized anxiety disorder is another diagnostic challenge here. People with GAD worry excessively about many aspects of life, including work, relationships, finances, and health. But again, in IAD, the anxiety is predominantly centered on disease and physical health. Body dysmorphic disorder should now also be considered. These patients engage in repetitive checking behaviours, but their focus is their appearance rather than illness. And their concern is they look defective or unattractive, not that they are medically unwell. So once IAD has been identified, treatment then becomes focused on reducing distress and improving functioning, rather than repeatedly searching for disease. And one of the most important therapeutic tools we have available to us here is the therapeutic relationship itself. These patients need to feel heard and respected, and dismissing concerns or suggesting that their symptoms are imaginary is rarely helpful, and in fact often can damage trust. Instead, clinicians should acknowledge the reality of the patient's distress whilst gently reframing the problem. And the goal here is to help these patients understand that the suffering they experience is genuine, even when a serious medical illness is not present. I've found that regularly scheduled follow-up appointments can be particularly effective here. Rather than encouraging symptom-driven visits, structured reviews provide opportunities to monitor concerns, address new developments, and especially reduce unnecessary appointments. Now, psychotherapy and not drugs remains the cornerstone of treatment here. CBT has the strongest evidence base and focuses on identifying maladaptive beliefs about health and illness. Patients learn to recognize their patterns of catastrophic thinking, reduce excessive body monitoring, and develop healthier interpretations of normal bodily sensations. This therapy also helps patients understand that normal physiological experiences vary from day to day, and by reducing hypervigilance and challenging distorted beliefs, CBT can significantly reduce health-related anxiety. There are other psychological approaches that may be beneficial. So mindfulness-based interventions encourage patients to observe bodily sensations without immediately assigning threatening meanings to them. Acceptance and commitment therapy may help individuals disengage from unhelpful health-related thought patterns and focus more effectively on valued life activities. Now, medication can sometimes play a role when symptoms are severe or when psychotherapy alone is insufficient, but it shouldn't be first-line treatment. Selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors have demonstrated effectiveness in reducing IAD, so for many patients, a combined approach involving both psychotherapy and medication can yield the best outcomes. If we look at prognosis here, patients who receive early recognition and appropriate mental health intervention generally experience better outcomes than those who continue to undergo repeated medical evaluations without addressing the underlying anxiety. Engagement with treatment, willingness to participate in psychotherapy, and a collaborative therapeutic relationship are all associated with improved recovery. However, severe and long-standing IAD can become highly disabling. Persistent anxiety may lead to social isolation, occupational impairment, financial strain from excessive healthcare use, and increased risk of other psychiatric conditions, including depression and additional anxiety disorders. Now, as GPs, our challenge is to recognize this condition early, validate the patient's distress, and redirect their care towards interventions that address the underlying psychological processes rather than perpetuating a cycle of repeated and unnecessary investigations. So that's a quick overview of illness anxiety disorder, previously known as hypochondriasis. And I do hope you found the podcast helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch with us via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.